बहुत अमाउंट उसका इसे यही से हो रहा है पीछे। हाँ, इसमें 15 मिनट्स दे रहा है, वैसे 20 मिनट्स अलॉटेड है, तो 5 मिनट वैसे ही कम है। आपने चेंज करो इसको, 20 मिनट्स लाओ। पहले ही डांट दिया सबको। राइट। So good morning, everyone. I thank Raipur Menopause Society for giving me this opportunity, and I'm going to speak on transforming severe PPH management, role of recombinant factor 7A.
Ma'am, can I give an introduction?
My introduction? Okay. इसको
Dr.
बस
Sangeeta Jogi, ma'am, she is the head of obstetrics and gynecology department, Bilaspur. And ma'am has been the past president of our society, and she has done tremendous work for our society. And she has started many programs and events, and she is very active. And plus, ma'am is also heading the MTP laws, rules, regulations, which work via the government hospital, Bilaspur. So, thank you, ma'am.
Thank you so much, Dr. Gitika. So now I will start my lecture. That is transforming severe PPH management, role of recombinant factor 7. We all know MMR in India is progressive towards global health target. Global prevalence of MMR is 223 per 100,000 live birth. India accounts for 12% of worldwide maternal death. The United Nations and SDG target is to reduce global maternal mortality rate less than 70 per 100,000 live birth. But in India, mainly 448 districts, they are more than 70% mortality rate. Just see trends of MMR. In 2014, it is 130. In 2017, it is around 100. In 2022, it is 88. And however, we further improvement is needed in maternal health care. Now, PPH is a leading cause of maternal death, accounts for 22.9%. And in India, it is worldwide. In India, it is 40 to 45%. We all know Ministry of Health and Family Welfare gave the definition. PPH is defined as blood loss of 500 ml or more within 24 hours after birth, or a small amount of blood loss that makes a woman hemodynamically unstable. The massive or severe PPH when blood loss is more than 1000 ml. By WHO criteria, PPH is commonly defined as blood loss of 500 ml or more within 24 hours, and severe PPH when there is more than 1000 ml within the same time period. The definition of severe PPH cannot be universal and can based on multiple factors like volume of blood loss, rate of blood loss, and shock index. This is the targeted treatment algorithm for severe PPH. First one is we use uterotonic at the clinical stage. Then PPH occurs, we can use oxytocin, prostaglandin, and other medical treatment is there. Then there is severity of PPH increases if bleeding is not controlled. So we can go for treatment progression like tranexamic acid, fluid and blood replacement, resuscitation, mechanical intervention, then go for invasive procedures, and lastly for surgical procedures. Now, the massive transfusion is an essential intervention for hemorrhagic shock but carries a significant potential complication like lethal triad of acidosis, hypothermia, coagulopathy associated with massive transfusion is linked to high mortality rate. Additional complications are electrolyte irregularities, citrate toxicity, and transfusion associated acute lung injury. Blood transfusion in trauma, surgery, and critical care are independent predictor of multiple organ failure, systemic inflammatory response syndrome, and high latent infection and increased mortality. The invasive procedures used to treat severe PPH are associated with various complications, and it could affect the future fertility and pregnancy outcome. Like a meta-analysis was done when there is uterine artery embolization was done. This patient have more history of increased rate of placenta accreta. Likewise, Main complication related to emergency peripartum hysterectomies are massive transfusion, febrile morbidity, need of re-exploration because of persistent bleeding and febrile morbidity, major surgical complication, and maternal deaths. So, despite advancement in the healthcare, severe PPH continue to be a significant cause of maternal morbidity and mortality. There is a need of rapid acting, non invasive medical intervention to avoid need for surgical procedure and to decrease the requirement of massive blood transfusion. A recent advancement is the treatment of severe PPH is utilization of recombinant factor 7A. So, approval of factor 7A in Europe and in India in November 2022, that is with Central Drug Standard Control Organization. Recommended factor 7A is indicated for the treatment of severe postpartum hemorrhage when uterotonics are not insufficient or not effective to achieve hemostasis. So, where is the position of recombinant factor 7A? First, we use clinical stage oxytocin. If PPH occurs, then oxytocin and other drugs. And after this, that the second step is position of hemostatic agent, recombinant factor 7A. It can be used any time of progress of the treatment, like before tranexamic acid or after tranexamic acid, before fluid and blood transfusion, or simultaneously with one hand this thing is going on, other hand we can use recombinant factor 7A. Before invasive procedure, and lastly before hysterectomy. So what is the horizon of recombinant factor 7A? It's a wide range. It treats prevent bleeding during surgery invasive procedures in patients with congenital hemophilia A and B with inhabitators, acquired hemophilias, congenital factor 7 deficiency, and Glennsman's thromboblastemia. It is now approved for the treatment of severe PPH when uterotonics are insufficient to achieve hemostasis. How it works? It's worked locally at the site of vascular injury where tissue factor is exposed and activated platelets are found. The binding of factor 7A to tissue factor initiate the coagulation and they found a small amount of thrombin is formed. But at pharmacological doses, this injection directly activate factors 10 on the surface of activated platelet resulting in thrombin burst. This thrombin burst leads to a formation of stable hemostatic plug which control the bleeding. So this recombinant factor 7A permits a rapid and safe initiation of treatment once a bleeding episode is identified. Like bleeding is recognized, first reconstitute the drug, give it will take 2 to 5 minutes time, then give low infusion volume, a fast administration, that is bolus injection is given IV and the amount is only 5 ml. Peak activity within 5 to 10 minutes and fast bleeding control in 90% of the cases. What are the dosing of this injection? 60 to 90 microgram per kg body weight. With IV injection, bolus injection is given and the peak coagulation activity expected in 10 minutes. Can we give second dose? Any recommendation? Yes, we can give only after clinical assessment. After 30 minutes, if if you think the hemostasis is not properly managed, then we can give. So, what are the prerequisites for maximum effectiveness of this doses? Major source of bleeding should be controlled. That means if the artery is oozing or bleeding, and you just thought, no, हमको तो injection देना, not like that. So, major source of bleeding should be controlled. Blood product should be administered to correct major deficiency before administering this injection. Patient temperature, pH, and calcium level should be adequate. Suggested parameters are platelet count should be more than 50,000, fibrinogen level more than 50 to 100 milligram per deciliter, pH should be more than 7.2, and absence of hypothermia and hypocalcemia. Dose is 60 to 90 microgram per kg body weight, IV bolus, as I told you. These are the few studies, randomized control trial done in France and Switzerland, and their objectives are to assess the efficacy and safety of single injection given to women with severe PPH. And they also assess the absence of need of specific second line therapy upon this drug. So, randomized control trial, they found 44% relative risk reduction in the requirement of invasive procedures to arrest bleeding, and bleeding is stopped in 90% of the cases. Similarly, similar studies done in India also. These are a retrospective observational study, 47 patients, and they assess the requirement of blood products before and after recombinant factor 7A, requirement of invasive procedure before and after, and blood loss, volume of blood loss before or after. The safety assessment, incidence of thromboembolic events in 30 days. So, so what was the result? The blood products which needed are before injection is 2.80 unit. After injection, it's 1.6 unit, just half. And blood loss, which is around 1200 ml, reduced to 220 ml. Both the specific values are, p values are less than 0.001, very specific. So one of 47 patient out of 47 patient with severe PPH required invasive procedure after receiving this injection. Hysterectomy, no patient needed hysterectomy. Results are similar with patient of thrombocytopenia, and no thromboembolic events were reported by this study. Another study from India, 38 patients with severe PPH, significant blood loss. They recorded 1252 ml and that reduced to 299 ml, 299 ml after injection. Similarly, 78% avoidance of invasive procedure, 84.2% bleeding stopped, blood products used 6.6% before injection, and after it is just half, 2.92 units, and they recorded no thromboembolic events after 30 days of injection. So, India real world experience key highlights from these studies are: there is no or less amount of bleeding after this injection, no or minimum amount of blood products required, only one dose is required predominantly, and there is decreased requirement of invasive procedure. None had complications like venous superficial or deep vein thrombosis and any myocardial infarction or ischemic stroke. So useful to be used as early adjuvant therapy to the standard management of practice of severe PPH. These are the robust evidence of severe PPH globally, so many studies, and they found the same result. Now, come to the long-term safety data of use of this molecule. The objective is to report the safety profile of recombinant factor 7A, 20 years of study, and 5.4 million standard doses are tested. And they found only 217 thromboembolic phenomena, that is 0.0004%, quite low. So, integration of recombinant factor 7A into Indian PPH guideline and recommendation in 2022. FOXY PPH guideline is there, 23 times of gynecology, then FOXY focus in 24, and topics in obstetric PPH. Now, PPH manual of FOXY and Armed Forces Medical Sciences, they included in their protocol or manual in 2025. FOXY focus recommendation or on this injection. Let's see. FOXY focus recommendation of recombinant factor 7A. Firstly, we have to initiate the management universally, include aggressive medical therapy with utrotonic, tranexamic acid, fluid resuscitation, blood products replacement, along with mechanical methods such as uterine massage, balloon tamponade, and cause specific intervention, as I told you. Then recombinant factor 7 is considered in the second step when bleeding remain uncontrolled despite of these standard measures, irrespective of etiology, whether it is atonic PPH, traumatic PPH, it's from the placental side origin or across both vaginal and cesarean deliveries. That means अगर एटोनिक पीपीएच है, ट्रोमेटिक है, नॉर्मल वेजाइनल डिलीवरी है, इंस्ट्रूमेंटल है और आफ्टर सी सेक्शन है, you can use anytime. It used may be also extended as an adjuvant during and after hysterectomy in refractory cases. Sometime you have encountered after hysterectomy there is continuous bleeding is there. In these cases you can also use. If hemostasis not achieved, escalation of definitive surgical intervention, including compression sutures, arterial ligation, embolization, or hysterectomy is required. Overall, recombinant factor 7A serve as an important hemostatic adjuvant that can stabilize patient and potentially reduce the need for more invasive procedures. There is a dedicated chapter of this molecule in Armed Force Medical Service Hospital Guideline for PPH management. Now, some of the possible circumstances where early use of recombinant factor 7A can be considered, that is after failure of medical management of uterotonic, when no blood is there, before the symptom of severe thrombocytopenia, hypoxia, and organ injury appear, before surgical procedures such as hysterectomy or laparotomy, before medical procedures such as uterine artery ligation or embolization or internal artery ligation, in case of vaginal delivery after balloon tamponade, in case of lower segment C-section after B-Lynch and uterine suturing, there is still bleeding is there, you can use this for conservative management for focal placental accreta patients. In patient with diffuse venous oozing, while arterial ligation was done, but oozing is this from the venous side. While transferring from the patient of from the district hospital to the periphery, you can use this injection. So what is this injection? That is Aptagogue alpha, a recombinant coagulation factor 7A. It contains powder and solvent. The strength is 1 milligram per vial and 2 milligram per vial. Now, after reconstitution, that means we have to mix this solvent with the powder and then we have to give IV bolus 5 ml stat. And the shelf life is 36 months after reconstitution at 25 degree. Before reconstitution it's 6 hours at 25 degrees centigrade and after reconstitution 24 hours at 5 degrees centigrade. So what are the key takeaway message? Postpartum hemorrhage is the leading cause of maternal death, accounting for 22.9% worldwide and 47 in India. This recombinant factor 7A is approved for the treatment of severe PPH when uterotonics are insufficient to achieve hemostasis. With peak coagulation activity expected within 10 minutes, it can provide a rapidly active, non-invasive treatment option for severe PPH. Recombinant factor 7A should be used as early as adjuvant therapy after the failure of uterotonic rather than as a last resort. Thank you so much.
Thank you, ma'am, for your outstanding presentation. I want to ask the cost of this recombinant.
Yeah, it's very costly.